not the least. I'm honored to be presenting this Dr. Bashir Memorial's lecture. Dr. Bashir, you probably don't know him. When I was very young in Lahore, I remembered him well. He was more famous than most of the cricketer, or his name transcended the all the people. He was as famous as a character or any celebrity. So before further ado, we start my lecture. It's only for 15 minutes. Medulloblastoma. Everybody knows about medulloblastoma, this undifferentiated small cell tumor arising from the cerebral neuroectodermal. It is one of the most frequent tumor in the childhood, especially, and it's the most malignant at the time. 20% of the childhood tumors are solid tumor is medulloblastoma, and at many times they do metastasis, and at times they present with metastasis. Now, at this present the time, most of the classifications are morphological classification based on histology. We have 4 types of different grades. One is classic medulloblastoma, desmoplastic, nodular, diffusely nodular, medulloblastoma with extensive nodularity, and large cell anaplastic time. But as the world is changing, there is more based on these. On the clinical factors and on the basis of morphological studies, we have done the risk stratification and prognostication was done. It was based on clinical factors, age. Younger the age, the more malignant it is, was considered. Extent of resection, we will come back to that, whether it's total, near total, or subtotal resection, or it was location posterior fossa metastasis, whether there is a CSF positive. Histology, diffuse classic is known as less malignant than as compared to the large cell anaplastic time. So based on these factors, the risk stratification was done, and it was done into an average risk stratification and the high risk. High risk was those people who has less morbidity, less than 50% chance of surviving for 5 years. Now, more and more transcriptomal studies are coming and molecular-based studies are coming. And before we go on to those studies, we will say this, with all this thing, if you look at this chart in 1970, there was only a 50% chance of survival of a child. And as it's coming up into 2000, 2005, there's 70 to 80% of the people do survive for more than 5 years with all the new medication and the treatment. Now, there is a chance that people may die of the complication of clinical radiation and toxic chemotherapy than of the certain types of medulloblastoma. So we have to be very careful about what we are treating, how we are treating, what is the type of medulloblastoma. Now, what's happening is that with this morphological transcriptional studies, now there was a consensus meeting in 2005 in Boston, which they have further subclassified medulloblastoma into 4 further types. Now, it can be subclassified too, but at this, the consensus was that there are 4 was based on. One was WNT, second was Sonic hedgehog type, third was because they were not able to classify it, they said it's 3 group or a 4 group. Now, these are based on the demographic or also on the, if you look at the WNT group, the most common finding was that there was a loss of chromosome 6, and there was a proliferation of MYC proteins, and it was named after because this groups there was a pathways, and because of the problems was coming in this pathway, and because of such trisomy 6, this pathway was affected, and on all those groups which this pathway was affected was producing this one group. That's why it was named as WNT. And the same thing was for the Sonic hedgehog. This was also a pathway in which the PTC receptors and the germline things were affected. There was, in this group, if you look at it, there was the trisomy 9q, 10q, and 3q was there, and there was the proliferation of MYC and proteins. Now, and the third was, which is considered to be group 3, is the most malignant one. Most of the time, if you look at it, the classic histology, there was large cell anaplastic type of the tumor. These are the one, they metastasize much more commonly, they are more often seen in the infant age group, less than 3-year age group, and while the group 4, which is considered to be of intermediate risk, is more in adults. And it's also at the pathology, the old pathology, if you look at the old pathology, they are more classic and LCA were more or less of the same group. And in this, there was the specific thing that there was a loss of 11p or the gain of one chromosome, and in which there was also a MYC protein proliferation. And they were also, because this, they were also the biomarkers in immunostaining assays were further done. And in WNT group, there was this beta catenin that was seen. And for describing any one group, you have to have at least 2 or 3 things positive to put that, categorize that patient into that group. Now, if we, the next slide is more or less the same thing. It's telling the Bond group has a better outcome. The pattern of relapse is much more local in the Bond group. And if you look at in group 3 and group 4, when the patient relapses, it doesn't relapse at the same site. The local relapses are not there, but it's always a metastatic relapse. And probably the different clones are there at the time of relapse than that was present at the first time. So that's why nowadays people are saying if something relapses after 2 years, they should again be biopsied because it might be different than the initial time. Because a lot of radiation was given, usually in the old days, 36 gray of radiation was given to this child. And this child, especially of low-grade medulloblastoma, is much more prone to secondary malignancies rather than the medulloblastoma itself. They are more likely to die because of secondary malignancy than of the group itself. And there are genetic aberrations, there are other aberrations which we have more or less. And why we wanted to classify these tumors on the basis of this molecular pathways. Why? Because they say when there is in one group, if there is one transcriptional problem, one transcriptomy problem, there's one chromosomal problem. The problem is probably all of these groups are going to behave in the same way. And if we are going to have one drug available that can control it, then they would be effective for whole of the group. And nowadays, the studies are coming with gemcitabine, pemidrex. They work against the smooth thin cell, and they are able to delay the relapses. And they are better able to work in anticlonal bodies working in the relapses, and they at times delay the relapses. Now, if you look at this, and based upon these molecular subgroups, there was a group that was the Heidel group that was all of the Neurosurgeons, 45 MAGIC consortium people from the 45 countries who were dealing with medulloblastoma tumors got together and they had a consensus meeting. And based on this consensus meeting, they re-described the stratification and prognosis of all the medulloblastoma. Now, previously it was only described average group, average risk, and the poor risk. Now they are describing low risk, average risk, high risk, and a very poor risk. And if you look at it, in the low risk, we have WNT Wnt group, and we have people of the group 4, which was previously described as the average group. If these are the patients which chromosomal 11, they are considered to be a very low risk patient. And should we be giving them the same amount of radiation? Should we be giving them the same amount of chemotherapy? So based on these people, patients who are come in Wnt and they don't have any metastasis, people in group 4 who don't have any metastasis, and there is a loss of or a gain of one chromosome, they generally behave really well. The rest are coming in, if in the sonic hedgehog group, which was considered to be average prognosis, but people with T53 mutations, these behave very poorly, even if these tumor doesn't metastasize. If the patient has a TP53 mutation, then they're going to behave, their risk is high to a very high risk. So based on all this, now the whole of the treatment paradigm is there is a paradigm shift in the treatment philosophy. This is the same slide, and this, low risk are the ones which are, which don't have any metastasis, which is, if you have done a surgery, there is less than 1.5 cubic centimeter of the tumor left. So in such patients, you can do a wait and watch policy rather than giving them high radiation or giving them low radiation of 18 gray or 23 gray. There are two trials, PNET 5 and COG trial. They are at this moment looking at this with the low amount of radiation rather than giving the classical radiation. And the chemotherapy we were giving before was cisplatin, CCNU, and vincristine. That too is toxic in the children. We are talking about lessening the chemotherapy too. Now, the COG4 trial, which saw a lot of retrospective patients, and saw one of the poor prognostic factor was the poor reading of the MRI scan. People who are treating medulloblastoma should know how on the MRI scan it looks like. Now I just put, this is the classification, biomolecular classification, that's the tumors over there. If you look at this, generally the bone tumors are also at the CP angle or in the cerebellum. Those with the sonic hedgehog type, they are usually cystic and in the cerebellar tissue. And they, if you do look at the enhancement, the contrast enhancement, they homogeneously enhances. There is a solid enhancement. Less than 80 to 90% of these tumor sonic hedgehog type would enhance. And if you look at in the third one, this is the group 3 tumors. Group 3 tumors, they are usually in the middle line, they're in the fourth ventricle, and they enhance patchy enhancement. And these are not a very regular enhancement. The people are talking about rectangle shape, beveled things. And if you look at the fourth slide over there, and that shows it in group 4, these medulloblastoma don't enhance on contrast. They enhance less than 10% of these tumor only enhance on the MRI scan. So this is very important. If you look at it and you can see that if you read it, and also if you are worried about if the tumor is enhancing or not enhancing, before taking the patient to surgery, you wanted to do the MRI of whole the axis of the spine axis to see whether there is any metastasis. If there is a metastasis, you know that the patient has got a poor risk. Now, this slide, number 1 is we want. Number 2 is solidly enhancing is the sonic hedgehog type. Third is the group 3, and the group 3 is the most malignant, and they comes into a very poor to a poor risk. And the fourth is group 4. Group 4 comes into the intermediate, and there is no enhancement over there. So in future, we are talking about how to reduce the mortality, how to reduce morbidity, and what should we do to increase the understanding of the disease biology. Until unless we don't know the disease biology, we would always be doing a catch-up phenomena. So all we are surgeons over here, we are all interested in what to do about surgery. Naturally, whenever this is there, we have to do resection. Now, how much resection is needed? People are talking about supramaximal resection, but here, all the studies have shown that less than 1.5 near total to a gross total resection is the same thing. A near total resection is that when you try to remove every bit of it. Gross total is when you try to remove. Near total is even if you maximal safe resection. If you leave 1.5 centimeter of the tumor, near total and gross total resection results are the same. And having said that, this study was done 25 years ago. This is the pre-MRI era study. People are talking about the inherent malignancy of the tumor. Even if the tumor is too large and you think you can't take it out, subtotal resection would be sufficient. But you should not be causing any new onset defects, neurological defect, because this is a patient who has got malignancy is not that bad and he has got a good lifespan, and if you got a neurological deficit, you have got paraplegic, hemiplegic, dyssymetria, so that would cause more problem than what the tumor was doing it for itself. So maximal safe resection without causing any damage to the patient should be our goal. Near total resection is not our goal. Surgical approaches is standard midline occipital one. Here, one of the most dreaded complication is cerebellar mutism. If you want to do medulloblastoma, one should try to do a telovalvular approach. Telovalvular approach has got less chances of getting cerebellar mutism. It is slightly tedious. You have to go a bit lower and then go to cerebellomedullary junction and then go upward, look at the tumor from below first, and then gradually move upward. But it has the lowest risk. Immediate postoperative construction is you can have all the complications, dyssymetria, ataxia, prelude low cranial nerve policies, transient cerebellar mutism. But usually these things resolve if you haven't caused any. Other question is, should we do a pre-option? Should we do a post-option? Should we do a EVD? Personally speaking, I never believe in putting a shunt in. No, especially pre-operatively, never. I used to do a lot of EVDs, but nowadays I try to stay away from it too. I wait and do a scan within 24 hours of the patient condition deteriorate, and depending on that, I put an EVD or a shunt. 50% of the people probably wouldn't need it. So, key message over here is that a residual over less than 0.5 cm is acceptable. You don't have to take every bit and scrap of it out and cause the patient disability. Avoid pre-op permanent shunt if possible. Use telovalvular approach whenever possible, and use all the technologies that is possible. I always believe these technologies always give you help and boost your confidence. QSA, navigation, motor evoked potential, EMGs, everything that's going to, because if you are doing a telovalvular approach, you wanted to know 11th or 12th cranial nerve. So motor evoked potential is going to help you. If you are acting the brainstem, you would have auditory evoked potential. So these things give you a lot of confidence, and you are able to do better resection. Coming to our experience, from 2014 to 2020, we have done 36 cases of medulloblastoma. And out of those medulloblastoma, 28 were the boys and 8 were the girls. Though having said the medulloblastoma, there is slight predominance of boys than the girls, but not that much. So that's a bit skewed. 5 of them was less than 3 years of age. 3 of them was, 19 of them was 3 to 10 years of age, and 12 of them was greater than 10, less than 18 years of age. Metastatic at the presentation was 10 of them had metastasis, 26 didn't have it. We did surgery on them. All of our group did. We did gross total resection in 22 of the cases, and in 12 of the cases, we were not able to we did a subtotal resection. And in one case, we just did a biopsy, or we did no treatment at all. On histology, 22 were classic medulloblastoma, 9 were desmoplastic nodular type, only 3 were anaplastic, and 2 were the diffuse one. Now, molecular subgrouping, we had a chance. There was this twinning program with the Sick Children Hospital in Toronto, and we were very lucky to have one of our spearhead is Dr. Noreen Mishtaq. I wish she was here today because I have borrowed heavily on her stuff too. I wanted to thank her. She has a grant, a $500,000 of grant, and because of that grant, we were able to send our slides to for molecular classification to the Sick Children Hospital, and of those, 5 came as sonic hedgehog. 2 of them were sonic hedgehog with P53 mutation. 4 were want. 3 were group 3. 4 were 14 were group 4, and 2 were inconclusive. So with this thing now, the risk stratification, initially we were saying 20 were on the high risk group, the poor risk group. We were thinking of giving him high dose of radiation and all this stuff. But come to think of it now, 18 had the standard risk. In the standard risk, you don't have to give very high doses of chemotherapy and very high doses of radiation. So everything changes with molecular thing. With 2 of them were P53 mutation. We know that whatever we do, the prognosis is poor. So you have to tailor. Now in future, every tumor would have a tailored therapy with clonal antibodies and all that stuff. 20 were treated with ACNS protocol for chemotherapy, 7 were the ACNS. These are the 2 trials on which they were treated. 3 had no treatment, and 1 only had radiation therapy, and 5 didn't opt for any treatment. Over here, because the treatments are costly, at times patient family don't opt for the treatment. 25 of those people are still alive after 4 to 5 years. They are off therapy and they are thriving. 11 of them expired. They died. Of those 11, 5 of them expired because after the relapse. 2 of them expired during the treatment. Probably our treatment was too toxic. Expired. 1 of them expired during the surgery, and 1 of them expired during the RT, radiation therapy. So in conclusion, what I would like to say is that the more knowledge we have, molecular subgrouping is the way forward. I know it's costly, but the time would come, it would become and there would be even more subgroups. Now, even with the P53, people are talking about wild type and the mutant type, and MYC proteins proliferation, gene deletion, gene loss, gene gain. All these things would come if further subgroupings would come. With further subgroupings would come, we would have more knowledge. When we have more knowledge, we would be able to do better treat it. Like we know that the WONT and there are certain in subgroup 4, they don't need very high toxic treatment. So we have to curtail our treatment. We have to tailor our treatment with every case. More knowledge with this in future, every case, every tumor would be histopathology, subclassification, molecular biology, transcriptional studies. All these things would come into play, and after that, they would the treatment would come. Thank you very much. If you have any question.